Thank you. All right, good evening, everybody, and thank you, organizers, for having me here today. So I know I'm the last talk, and I'm going to try and keep it short, crisp, and so for today's session, I've been given this mammoth task to actually talk about the role of molecular diagnostics in solid tumors. So we're going to start off with where we are, with our testing platforms and how these testing platforms like next generation sequencing, how important their role has come in clinical decision making today in our clinics, and we'll wrap it up with that. Right, so we know that physicians essentially and ideally want their results quick. They want answers immediately. They want to do it as soon as possible. And one of the key reasons for that is that in advanced cancers, in metastatic diseases, we know that with each line of treatment as a patient progresses, the PFS decreases. So they want to know the therapy options early. They want to know when and how they should switch therapy, call out those resistance mutations. And time and again, next generation sequencing has become our preferred platform of choice. Again, I'm not going to be belittling the standard of cares like FISH, RT-PCR. They do have their pros, but from kind of getting the overall picture, being super quick, NGS is fast becoming our preferred platform. So what does, and while our dependency on NGS increases, what does the workflow look like? You get your patient's sample. If you're doing germline, it's blood. If you're doing somatic testing, it can also be blood, but and you have tissue testing. So you take that sample, you hand it over to your service provider, it comes into the lab, it goes inside this mysterious black box, something happens, and a report gets generated. So while I say this half in jest, understanding the technical specifications, the nuances that go into next generation sequencing is extremely critical and important. And the reason being is there are a plethora of diagnostic labs, and NGS seems to be the flavor of the season, and everyone's putting in a next generation sequencing machine. Somebody's putting a NovaSeq, somebody's putting a Thermo Fisher S5. And when you get that report and you're analyzing it and you're looking at it, there are a couple of features that one should be looking into to ensure that that is a good NGS report, because you are making clinical decisions based on that. So what does this workflow look like? So step one is obviously you get your sample. The sample could be a simple tissue. When we receive that tissue biopsy in those formalin blocks, in those paraffin blocks, my apologies, the first step is the pathologist will do a tumor check. We run an H&E, we do a tumor check. It has to be a minimum of 15% good tumor tissue. So that's step one for quality. Simultaneously, if we're doing a germline test, we make sure that the sample comes in an EDTA tube. You make sure it's not hemolyzed. Or if you're doing a liquid biopsy, we use Streck tubes or Paxgene tubes. Again, over there, you look at and ensure that there's no hemolysis. Once the first step is cleared, then the sample comes into the laboratory. Now, what do we do here? Step one, we do DNA extraction. Once the DNA extraction is done, then we start what I like to call the most crucial part of this whole process is your target enrichment. It is at this particular junction that we decide, has this patient sample come in for a hereditary gene panel of 20 genes, 154 gene panel? Is it a 5 gene lung panel? Is it a 500 gene comprehensive genomic panel? It is at this point that this decision is made. And how is that done? Because from those DNA strands, you are putting in adapters. And what those adapters are essentially doing is that on that DNA strand, they're going and attaching themselves to your region, to those genes that you want to, that are part of that panel. They're going and attaching themselves, and those are going to be multiplied when it goes inside the sequencer, which I've been calling the black box. When it goes inside the sequencer, step one, obviously the DNA and the RNA, as we know, RNA sequencing is important, especially when we're looking for fusions. So your DNA, your RNA, these are getting multiplied. We are amplifying them. We're making multiple copies of them within the sequencer. And what's happening from there is that the biological language, it's like Google Translate. You're converting biological language into a language that hopefully a software can help us comprehend. So once that process is done, it comes into the next phase, which is alignment. Alignment means is that we have a reference genome. And this comes from the Human Genome Project, where we've gone and we've done a complete genome-wide analysis of a human being, and that becomes our reference. And based on that reference, these reads, which I'm just going to go here so it's easier, these reads, these little blocks that you can see, go and align to that reference genome. So if there's a part of chromosome 1, that part of chromosome 1, its location will go directly under the reference genome with the same geographical location. So once you've done that, it's aligned. Then we have various softwares that get applied in, which is what we call a bioinformatics pipeline. And what this is doing is that it's taking all that language and converting it into a language that we can understand. And over here is when they call out and say, this looks like a mutation, this looks likely pathogenic, this is pathogenic, this looks like a VUS. And we look, we analyze, and we understand this, because that's when you need a person, a genome analyst who sits in there, applies the right filters, because you cannot call out a polymorphism and say, oh, this is pathogenic. One has to be very cautious. So at points like this, once the variant calling is done by the software, a genome analyst, which is a human being, will sit over there and re-verify. Does that mutation, it could be a change, but is that really disease causing? We go into various databases to ensure, do a cross evaluation and see if I give this particular EGFR mutation or CHEK2, is this CHEK2 mutation actually pathogenic? Is it increasing my patient's chance of having hereditary breast ovarian cancer? Once we have that data, we have publications, we have all the data to support that, yes, we can report this. Then it comes onto a clinical report, and that's the report that you receive. So essentially, it breaks down into 4 phases. You've got pathology, which is and your wet lab. It goes onto the sequencer, my black box, and you go through. It undergoes the bioinformatics pipeline, and then eventually the reporting. Now, this is the basic process, which is followed irrespective you use Illumina or you use Thermo Fisher. So there are some key things that one must be on the lookout for when they are doing this NGS testing. When that report comes to you, if you are doing germline testing, there'll be a word over there, the depth of coverage. And all of us enjoy saying it. Like, when you'll have these laboratories coming to you and they'll say, oh, our depth of coverage is 500x and ours is 1,000 and ours is 200x. So how do you evaluate and understand, is this a good benchmark? Step 1, what is depth of coverage? Depth of coverage essentially means those reads, that DNA that you have amplified, how many times are you reading it? Are you reading it 10x times, which means are you reading it 10 times? Are you reading it 500x, which means are you reading it 500 times? And why is this important? Because the more you read, the more copies you have for those very rare mutations or those mutations in really, really small percentages, you have an opportunity to call them out. So when the depth of coverage increases, which means the amount of times you've read that particular read increases, you have a higher potential of calling out those very low frequency genes that are actually creating havoc in your patient's genes. And this is, again, just to give you a better idea as to, so you've got chromosome 1 and chromosome 5. Chromosome 1 here is in orange, and you've got chromosome 5, which is in blue. And over here, as you can see, these are just depicting the various somatic aberrations. And I say aberrations because they're changes. It's not always a point mutation. It could be a fusion. It could be a large deletion or duplication. And these are the various softwares that are within that bioinformatics pipeline that actually goes in and helps in that first step of calling out those mutations for us. The variant calling is actually done based on these particular softwares. Right. The second concept is variant allele frequency or mutant allele frequency. What that means is from all your reads, so I like using this, it's a very simple diagram over here where we've got these 5, let's call them marbles, in which out of the 5 you can see that so out of the 5 that you can see over here, 1, 2, 3, and 4, where we've got this red, there's a change, which is a mutation. So what this essentially is saying that out of these 5, 4 have a mutation. So 4 out of 5, that means it's 80% is the variant allele frequency. Now that's pretty high, but I'm just using this as an example. So your VAF is essentially the mutant reads. This is your pathogenic mutant reads by the total number of reads and that percentage. And these percentages actually help us decide sometimes in those somatic mutations as to who is your driver mutation and which one is your passenger mutation. Now keeping the depth of coverage and the VAF in mind, the third and the most important concept is that when you increase your depth of coverage, it increases the overall sensitivity of calling out those mutations. And why is this important is that in the case of, right, so as you can see over here, this is your depth of coverage. So ideally, when you have germline testing, a minimum of 100x on germline suffices. When we are doing tissue testing, a minimum of 250x should be the bare minimum that we're doing. Anything less than that for somatic testing is not acceptable on tissue. When we move on to liquid biopsies, because we do understand that liquid biopsies, for it to be at par with respect to sensitivity of tissue testing, it has to be a minimum of 10,000x depth of coverage. And that is why a lot of your liquid biopsy panels have a small, there's a very small gene list. They're around 75, 80, 54. No one does more greater than that apart from Foundation Medicine. And when Foundation does it, they've actually reduced their depth of coverage, which in turn has reduced the sensitivity of their test. So you've got to be a little careful that when we're doing liquid biopsies, tissue biopsy, or germline as to what the depth of coverage is. And why is NGS important? Because we know that it's not just one driver gene. It is a combination of multiple genes that is actually driving this cancer, that is causing this cancer. And what next generation sequencing does is, in an ideal case, it gives you the entire biology of the tumor. And while, as we've seen from a lot of our previous speakers, is that while it's not always about being actionable with a target, with a therapy, it also, these tumors, we understand not only prognosis, in some cases we can understand as to what type of chemotherapy will work or not work for this patient. So it gives us a better understanding as to a more educated understanding as to how we can personalize treatment for a patient. In addition to that, it does preserve tissue, especially if we're using these newer platforms of Illumina and Thermo Fisher of anywhere from 20 nanograms to 100 nanograms, you can get the entire biology of your tumor. Obviously, it depends as to what panel you've chosen and how many genes, but all this is a comprehensive approach. Right, so what are our sample types? Tissue is always the gold standard, I stand by that. But the ground reality is that sometimes every lab does not, unfortunately, follow the right protocols in preserving and in embedding these tissues in paraffin, which in turn sometimes, because the high percentage of formalin can cause DNA degradation. So while you, and the pathologist will say, nope, there is tumor testing, but when it comes to us, the quality of DNA is really poor, and those sequencing reads are not clear. We see a lot of noise. So in cases like that, we do see DNA degradation. So that's one example, but sometimes it can also be tissue is inadequate. So in cases like this, we do have liquid biopsy, which is fast becoming an excellent sample type, especially for our metastatic disease. So in liquid biopsies, we're looking for, because we're talking about therapeutics, we're talking about circulating tumor DNA. Circulating tumor DNA is essentially that cancer cell of yours which lyses and releases that somatic DNA into the bloodstream. So from the blood, we isolate that somatic DNA, and on that, the molecular profiling is done. Circulating tumor cell is essentially those intact tumor cell, is the intact cancer cell that is, circulating within the body. And we use CTCs. It is an upcoming field. There's some amazing work happening there. We do use it more from screening and monitoring perspective, but it's not really come 100% into our clinical practice. But I think we're nearly there. Right. Now, one of the key benefits, sorry, let me just go back. One of the key benefits that I feel where liquid biopsy kind of trumps tissue biopsy is that because it's non-invasive, you can actually use it for treatment monitoring. You can call out those resistance mutations upfront before your patient progresses. So it's non-invasive upfront. And one of the key, I think, concerns we've always had around liquid biopsy has been its concordance and sensitivity with tissue biopsy. And we've got a plethora of clinical studies that have come out. You've got your SLIP study, you've got your Nile study, you've got your plasma match studies. And all these studies very beautifully did a head-on-head comparison where they took tissue testing and liquid biopsy, and they tested a patient. And what they saw was that liquid was not inferior to tissue. So in a metastatic case, I do think that liquid biopsy is an extremely good option, especially when the tumor burden is high. And in the case of lung cancer, and that's the only solid tumor where stage 3B and above, you can actually use a liquid biopsy. The others, it has to be metastatic. Now, what I said about liquid biopsy, while for resistance mutations and all, it's got another plus point, which is calling out tumor heterogeneity. And especially in those advanced cancers, metastatic cancers, it plays a vital role. So there are two key clonal evolution, or the changes that come in, the different types of heterogeneity that come in which liquid biopsy helps us call out. One is linear clonal evolution. That's very typical of what we see in our lung cancer patients, where you've got one driver mutation and you've got a passenger mutation, and after lines of therapy, that driver goes into the back seat and you've got a new driver mutation. And this old one, because the treatment has been removed and there's a new passenger coming, which will eventually be your driver mutation. So this is something that we see commonly in our lung cancer patients, which essentially means that the dominant gets replaced over time by either a new mutation or most likely a passenger mutation. The second one is what we call branch clonal evolution, where there's not just one dominant clone, there are multiple, like we see in our head and neck cancers, which follow a very different, the tumor biology over there is completely different from your other solid tumors. So in branch clonal evolution, we see all of these changes that are happening simultaneously in which the disease is presenting in a patient. So while we talk about NGS and we talk about its application in our clinical practice, in the last couple of years, we've actually learned some very important lessons from these targets and from NGS in our clinic. So lesson number one, it's not always about going in for that 500 gene panel and that 200 gene panel. It's actually about understanding what is your target gene. It's doing a correlation of the patient's clinical history with the possible tumor biology. And I love using this particular example of where just one gene was enough. This was a case of a melanoma patient with metastatic subcutaneous deposits, and he had barely a 5% response rate on chemotherapy. And somewhere at this point, they went in and they, because we know with melanoma, BRAF is synonymous with melanomas. So they did a simple BRAF by RT-PCR. They looked at BRAF V600E, V600K, and another one that I can't remember. And the patient came positive for BRAF V600E, which we know constitutes for around 60% of our melanoma cases. And the patient was started on a BRAF inhibitor. And as they say, a picture speaks 1,000 words. The second lesson we learned is that targeted therapy was superior to chemotherapy, especially in our molecularly matched patients. So the first one that we have over here is our is in lung cancer, where we had an EGFR mutation, where we head-on-head comparison of geftinib, which is a TKI, first-generation TKI, with chemotherapy. And the second one they did it was with a BRAF inhibitor in a positive melanoma patient, and with chemotherapy. And as you can see, with these beautiful separations in these Kaplan-Meier curves, the patients that were molecularly matched fared far better than those who weren't. Now, this is, I think, where precision oncology and molecular oncology is headed, is in tissue agnostic. And, you know, we've seen it with tumor mutation burden, we've seen it with MSI, MMR, we've seen it with NTRK, RET, which has orphan drug status. So we're reaching a point where it's actually about understanding what is the biomarker and finding that as a target irrespective of the tumor type. Now, again, take it with a pinch of salt. You do need, obviously, a lot of research work. You need clinical trials to prove it. So like we've seen over here, these waterfall plots show for pembrolizumab, which was approved for pan-cancers, for patients who had an MMR-deficient tumors, and in these NTRK fusions, where I've shown entrectinib, but even with larotrectinib, across the board, for all solid tumors, patients had a very good response. And it was based on these waterfall plots that the FDA gave a blanket approval. Then in 2020, based on the Keynote 158 trials, we got a blanket approval for tumor mutation burden for across all solid tumors if the TMB was high, for adults, and actually even for children. Now, with this agnostic marker, I have a slight concern, because if you go back and we look at the data, it's not for all solid tumors. The number of patients that were enrolled for your breast cancer, your NSCLC, is practically minuscule. So a one-size-fits-all percentage, a cutoff of, you know, if you're using the foundation panel, it's around 10 mutation, it's 10 mutes per megabase or higher. And if you're using, the Thermo Fisher one, like the one we use internally, is around 20 mutations per megabase. So if you look at these cutoffs, it's not a one-size-fits-all. I do feel that this is still experimental, but when they've got your back up against the wall, you have your FDA approvals, why not? It's a good marker to use. But like PD-L1, we've had various cutoff scores for different solid tumors. This is something that TMB needs to work on, because every patient will not have that response. So understanding tumor biology is important. That's the fourth lesson we've learned, because one target, one drug, we know will eventually lead to resistance. One target, one drug does not really inform you of all the potent targets, and one target, one drug does not give you the whole picture. And we've got some of those tumors that, even though they molecularly match, no matter what you do, the patient does not respond well. And that's because that particular tumor type is actually addicted to immunotherapy. And because of that, it becomes essentially important that when you are looking at immunotherapy markers, you cover all three upfront for your patients. NGS has again helped us in looking after our patients who have, those rare and very difficult cancers. And what does the landscape look like? I need another 10 minutes and I'm done. So what does the molecular landscape? Okay, 5 minutes. Okay, so what does that landscape look like for us? This is how we're treating our patients. You've got a combination of targeted therapy, you've got chemotherapy, you've got your checkpoint inhibitors, you've got a combination of all of these. And this was an excellent study that came out from the MSK group, where they took around 10,000 patients, and from this 10,000 patients, they went and did molecular profiling. And what they saw was that around the sheer cohort of patients that got molecularly matched and responded well to therapy was phenomenally high. And interestingly enough, those GE and GI cancers, which we usually tend to ignore in our clinic, they are the ones that had the most maximum number of druggable mutations. And similarly, they also had a high TMB score. So this is the current algorithm. This is the poster child, I think, NSCLC for all the targets that are available. Ovarian cancer is another upcoming area. We've got fantastic work happening over here while we have chemotherapy, we have immunotherapy. But I think the area that, and your agnostic markers, but the area that I think is becoming really, really relevant and important is the concept of homologous recombination deficiency. We have seen this, I think this pie chart comes in every talk. It's very popular. But what makes ovarian cancer so very unique is that nearly 50% of these patients, if you look at these, are HR deficient, which in turn means that they're going to respond well to either platinum therapy or a PARP inhibitor. So what are we testing for when we do homologous recombination defect? We're essentially looking for a change in when a cell cannot perform homologous recombination repair, it becomes homologous recombination deficient. So what you're looking for is either a BRCA1 or BRCA2 mutation in the somatic or germline. You're testing for those genes that are involved in homologous recombination repair. There are around 17 of them that we test for that have clinical relevance. If you find a mutation in their somatic or germline, we look at the genomic side of it, which is the BRCA promoter methylation, and those undetermined causes. If any one of these is present, it means our patient's tumor has the inability to repair, which in turn means it's genomic unstable. So we look at the mutational and the genomic landscape. If either of this either or both have a problem, we send the patient responds well to a PARP inhibitor. Now, there's a very important thing to look out for when we're doing ovarian cancer testing, and this was a patient of mine, and this was a very important lesson we learned, was that this was a patient of mine. She had no family history, and we sent her, she was diagnosed with ovarian cancer, went to remission, had a relapse, and at this point we sent it in for molecular profiling. We found a BRCA1 mutation, and interestingly enough, based on that VAF, that's a pretty high BRCA1 mutation. And we came to know on later studying that it was actually a germline mutation. And to drop that bomb on a patient who's already really disturbed and upset with the fact that she's had a relapse. In a case like that, pre-test genetic counseling, especially when you're doing for prostate, ovarian, breast, and pancreatic cancers, when you're looking at these HRR testing is extremely important. Similarly, we've got a plethora of tests that I'm going to very quickly go through these, a plethora of tests that are available for breast cancer, triple negative, your HR positive, HER2 negative. This is a more personalized way of how we look at these algorithms. And the most important concept, because we are talking about BRCA time and again, is a concept of BRCA reversion, which essentially means that in your heavily pretreated patients, sometimes that BRCA mutant becomes BRCA wild type. It partially restores its protein function, because of which the patient becomes insensitive to platinum therapy and it becomes insensitive to a PARP inhibitor. It basically behaves like a BRCA wild type, right? So this is something you've got to be very, very careful of in those heavily pretreated patients. CRC, we've got a plethora of testing options. GE cancers, we tend to ignore them, but these guys actually are extremely heterogeneous, and they're more heterogeneous than your GI cancers. And they're, again, a lot of targetable biomarkers. Similarly with biliary tract, which once used to be considered a really boring homogeneous group, but this is very heterogeneous, and based on its anatomical location, we see in interhepatic and gallbladder, FGFR2 fusions, and IDH1 is more prominent, whereas in gallbladder and intrahepatic, we see HER2, and obviously you've got your BRAF and the MMR and your agnostics. Pancreata, poor prognosis, it is a known cause of, it is a poor prognostic outcome for our patients. And because of that, what the NCCN did is that even without clinical trials to support it, in the guidelines, we actually are recommended to try all these biomarkers, which have obviously adjoining treatment to help those patients. So these are the changes that we see. And this is my second last slide, which is that while we paint a very rosy picture of NGS being the future, there are certain lacunae, there are certain areas that I think we need to still work on, right from processing to having the right genome analysis and actually understanding the tumor biology, the molecular genetics in it, and its application in our clinics, and obviously cost. We are a cost-sensitive country. And I want to leave you with this last slide. I think this is where we are today in diagnostics. It is not just about NGS, it's about doing a combination of everything. Understanding and getting the whole tumor, getting the whole story, the whole picture is extremely important. And on that note, thank you very much for your patient listening.